Can you hear me?
Yes, we can hear you.
We can hear you, Dr. Renato.
Okay, so are we online? Can we start?
Please start. Ma'am, please start.
Hello, good morning, everyone. I'm very happy to be here with this very exciting program about phakic IOLs. We are still in the quarantine time because of COVID-19 and trying to take advantage of the time and the opportunity to share information, to learn from colleagues all over the world. And I'm really, really happy and excited to participate on this webinar with my colleagues, Sri Ganesh and Dr. Bradra from India. They have done a huge work in every aspect of refractive surgery, including corneal surgery, phakic IOLs, pseudophakic multifocal lenses. So we are really happy here and excited to learn a lot from the work. So with not wasting more time, I'm very happy to start the program. And I have my friends, my co-moderators, Dr. Bruno Fontes, who is the current president of the Brazilian Association of Cataract and Refractive Surgery, and Dr. Mayumi Nakano, who is also a very experienced surgeon here from Brazil. She's from Sao Paulo, and she's definitely going to have plus on the understanding how to discuss and to improve the learning from phakic IOLs. So the first talk is going to be by Dr. Sri Ganesh from India. Is that correct?
I'll be coming first, Sheetal.
Dr.
Dr. Sheetal Brar is coming first with. I don't have the program, so I'm sorry because I don't have the connection of the internet. So I'm using the current 4G Wi-Fi. Those are the technical issues that we are facing with the pandemic. Sometimes things don't work as perfect, and we are really learning how to deal with that. So I'm looking forward to learning from you, Dr. Sheetal, and please, thank you very much for your time, and let's start this great program. Thank you.
Good evening. Thank you, Dr. Renato. And I would also want to thank Biotech Vision Care and Mr. Khalsa especially for inviting me to this wonderful webinar on phakic IOLs. I have two presentations. Are my slides visible?
Not yet. Now they are.
Can you see the slides now?
Yes. Now I'm back
able
to
to see?
you.
Okay, 1 second. I'll share my screen again. All right, can you see now?
Perfect. Thank you.
Good. So let's talk about patient selection, pre-operative evaluation, and treatment planning with phakic IOLs. How do I advance it? Okay. So just for the introduction's sake, we all know that this is the spectrum of refractive surgery. We have cornea-based procedures, we have lens-based procedures, and combined cornea as well as lens-based procedures in the form of bioptics. A phakic intraocular lens, as we all know, is a lens which is placed inside the eye in front of the patient's natural crystalline lens. And there are essentially three types of phakic intraocular lenses: anterior chamber angle fixated IOLs, iris supported phakic IOLs, and posterior chamber phakic IOLs. However, the first two types of lenses are not really very popular now because of some unacceptable complications with which these lenses are associated with, such as progressive loss of endothelial cells, iris atrophy, secondary glaucoma, UGH syndrome, etc. So nowadays, the posterior chamber IOLs are more popular, and they have already shown a long track of safety and efficacy. There are three types of posterior chamber phakic IOLs available in the market at present: the iCryl phakic IOL from Biotech Vision Care, the Evo Vision ICL from Star Surgicals, and the IPCL from the Care Group India. So talking about the advantages of posterior chamber phakic IOLs in general over the angle supported and anterior and the iris fixated lenses. Now, because of their position, which is quite favorable, the position is behind the iris, and they are placed in the sulcus. So they are far from the endothelium. So endothelial safety is much better. The cosmesis is much better since they are close to the nodal points of the eye. So essentially, that's why the patient always has a gain in the vision after the correction, and also gain in the retinal size of the image. And we get effectively a larger optical zone when it is projected at the corneal plane. So for optical zone of 5.5, you actually get an effective zone of about 6 on the cornea. And because it is placed in the sulcus, it can be easily removed or exchanged. It is not fixated onto any tissues such as iris, and therefore there is no risk of long-term problems such as pigment dispersion and pigmentary glaucoma at all. And it does not alter the shape of the tissue. We'll discuss how they are better from LASIK and other corneal refractive surgeries, and they're completely reversible, and they don't lead to any loss of accommodations, which is the biggest advantage. So comparing phakic IOLs with the corneal refractive surgeries such as LASIK SMILE or PRK, these lenses have the ability to provide very sharp and clear quality of vision, and the patient experience is not much different. So the procedure itself takes about 15 to 20 minutes in experienced hands. There is no removal of corneal tissue, and hence it is not a permanent type of correction, and it does not cause much contribution to the dry eye, and it's considered to be very safe because if there's any issue, it can always be removed or reversed. And it also provides us the flexibility for performing future procedures such as bioptics if the patient's myopia is much higher. And it also has the ability to treat, like you can treat thin corneas, which of course with LASIK or other refractive surgeries, corneal surgeries, is not possible. These lenses have a UV protection, and especially the iCryl phakic IOL also has sphericity, so quality of vision is also quite good, and the material is hydrophilic acrylic, does not have any porcelain polymer, which is very good, which has a good uveal tissue compatibility. Also comparing posterior phakic lens implants with refractive lens exchange or clear lens extraction. Now, this is a good option for patients who are above the age of 40 who are already presbyopic. So we can perform this on those patients because they need presbyopia solution also. However, for younger patients, this involves higher risks of retinal detachment, CME, PCO, and if you add them, this also increases the risk of retinal detachment and an irreversible loss of accommodation. Now, coming to the workup of phakic IOLs in general and iCryl phakic IOL in particular. So you have to select the right patient, and also you have to select the right lens. Basically, the sizing and the power selection should be accurate. So indications of phakic IOL surgery: generally, they are the same indications which you have for the corneal refractive surgeries, as in the patient's age should be 21 years and above. The refraction should have stabilized. So you should have a stable refraction for the past 1 year or so. Patients who are, of course, not suitable for SMILE, LASIK, or PRK due to high powers or thin corneas. Very important, the AC depth should be more than 2.8 millimeters. And the endothelial count should be more than 2000 cells per millimeter square. And they should not have any other ocular pathology. Contraindications also are pretty much the same. If the patient's refractive error is progressive, then you should wait for the number to stabilize. Any kind of corneal dystrophies, low endothelial counts, corneal scarring, advanced keratoconus, anterior chamber depth, which is less than 2.8 millimeters, or any other ocular pathology such as history of uveitis, if patient has synechia, any angle or glaucoma pathology, or evidence of nuclear sclerosis or development of cataract. Very important, personal or family history of retinal detachment. Now these patients are very high myopes. They have an inherent risk of development of retinal detachment in future. So this history is very important. And also they should not have any other retinal degenerations or pathologies. They should not be on medications such as the long-term medications on steroids or immunosuppressants, and pregnancy is also a contraindication. Now, preoperative assessment, you have to do a careful assessment and perform all the tests such as the refraction, slit lamp examination, intraocular pressure, dry eye examination, corneal topography. Now, these are the tests which you normally perform for corneal refractive surgeries as well. However, for phakic IOLs, anterior chamber depth and white-to-white measurements are additional investigations which must be done very carefully. Specular microscopy, dilated retinal examination, and also axial length measurements should be performed in these patients, since they always have a chance of progression of myopia later. So regarding refraction should be done objectively, and should subject the patient, you should correct the patient to the best corrected visual acuity. It should be done at 12 millimeter vertex distance, because this is the vertex distance at which the calculation of the lens power is performed, is done with the online IOL calculator. And of course, it should be stable for the last 1 year. If the patient is highly myopic, or if the refraction is changed, it's better to do a cycloplegic refraction. And also we should try to give a slightly use a less myopic value, so that you don't make the patient hyperopic later, because it's always good to leave a myopic patient slightly myopic. Now, a careful slit lamp examination, as for other refractive surgeries, is again very important, because you want to rule out any active infections or inflammations in the eye, severe dry eye, corneal dystrophies, corneal scars, any peripheral corneal degenerations or thinnings or pterygia, lid abnormalities. All these pathologies would interfere in the correct measurement of white to white measurement, because this is extremely important for the sizing of the phakic IOL. So we must pay attention to all these. Also, orthoptic evaluation is important, because these patients are highly myopic, and they may have a variety of orthoptic issues such as isodeviations, exodeviations, and intermittent, latent, or constant type of squints, which may get complicated by amblyopia, anisometropia, convergence insufficiency, etc. So it's good to do a proper orthoptic evaluation, especially if possible by a squint specialist. And there have been various studies, and they have found that generally ocular alignment and binocular function for most of the patients doesn't really change after an ICL surgery. However, patients who have exodeviations, they have shown to improve in the deviation after the procedure. However, this has to be explained to the patient very clearly, that after the phakic IOL surgery, the ocular alignment or the squint may or may not change. So this is an important point, because sometimes they think that this will also correct the squint as well, along with the power. Intraocular pressure is again very important test, because of these lenses, they are placed in the sulcus, and sometimes because of pigment dispersion or due to the vaulting issues, there can be rise in the intraocular pressure. So non-contact tonometry is a good screening test. However, as we all know, Goldman applanation tonometry is the gold standard for this. So if possible, Goldman applanatometry should be done. Gonioscopy is not is not compulsory. However, for patients who are above the age of 40 years or who have narrow angles by Van Herrick's slit-lamp grading, or if they have a family history of glaucoma, then it is important to also perform a gonioscopy and counsel the patients accordingly. Dry eye evaluation again is important, although it may not really affect the white to white or the anterior chamber depth measurements. However, you need a good ocular surface to capture reliable keratometric values, because you need to input the keratometric values also in the online calculator. So this is important. And most of these patients will be contact lens wearers and are always predisposed to dryness. So they should be also treated, and preferably non-contact methods such as the SBM tearscope and HD analyzer, which we have in our institute. They should be used because they don't involve any kind of touch with the surface of the cornea, and they give NIBUT values, which can be used for the dry eye assessment, and corneal topography. So it's important to discontinue soft contact lenses for five days, and RGP lenses for 3 weeks prior to the corneal topography. Now, many of these patients you just send for corneal topography, but eventually we'll find that some of them have a keratoconus or a suspicion of keratoconus. So your plan of management can actually change entirely. So then for these patients, you would want to stabilize the keratoconus and then wait for about 3 to 6 months, and then plan a phakic IOL. Also, it tells you about the astigmatism, whether it's regular or irregular. And specular microscopy is again important because normally also there is a physiological loss of endothelial cells. The rate is about 0.3 to 0.6%. And most studies have shown that the mean endothelial cell loss after a phakic IOL surgery could be anywhere from 0.2 to 1.2%. So, and your surgery is definitely going to impact this rate of loss of endothelial cells, which is ongoing. So it's best avoided to perform these surgeries in unhealthy endothelium patients, and ensure that there's a minimum endothelial cell density of 2000 cells per millimeter square, and the endothelium should be of healthy, the cells should be of healthy morphology. And these, if patients have a compromised endothelium, or just in case you have to do the surgery, it's also good to check the specular microscopy every yearly when they come for annual follow-up. So dilated retina examination is extremely important because these very high myopic patients also will have myopic macular degenerations, CNVM, posterior staphyloma, and most importantly, peripheral retinal degenerations such as lattice with or without holes. So if any of these pathologies, especially lattice generation with holes, is present, it's very important to perform a barrage laser treatment. And generally, this is the consensus, although it is a bit debatable when is the right time to perform a phakic IOL surgery after retinal laser. However, 2 to 4 weeks is what most of the refractive surgeons kind of agree with, and only after a repeat IDO, once you see that the laser has well sealed all the holes and the weak areas, then it can be, you can go ahead with the phakic IOL surgery, and also regular follow-up must be ensured. So coming to the anterior chamber depth assessment, it's very important to measure the AC depth from the endothelium. So it's the internal ACD which has to be measured, and which is important. It should not be less than 2.8 millimeters. So if your machine is not showing clearly that it's an internal measurement, and if it's an external one, what you need to do is that you need to subtract the corneal thickness from the anterior chamber depth, and that will give you the internal ACD. So various measurements tools can be used to measure the anterior chamber depth, such as the optical pachymetry using OBSCAN, Pentacam, Sirius, Galilei. All the modern tomographers are these days providing these values. And ultrasound biometry using the A-scan also can be done if you don't have access to the high-end tools. Immersion is always preferred, and optical biometry using the IOL master lens star also can be performed. Nowadays, We also have ASOCT based tomographers such as MS39. We have this with us in our institute, so we also use this. Very important that the white to white measurement must be performed from the mid part of the limbus. So the limbus has the outer limbus, the inner limbus, and the mid limbus. So from the mid limbus, which lies in the mid of the clear cornea and the junction of the limbus and the conjunctiva. So it should be from here that you should measure. So horizontal white to white from mid limbus of the nasal side to the mid limbus of the temporal side has to be measured. And various tools can be used, calipers, which can be the regular manual caliper or a digital caliper, has been found to be a proven and a simple, reliable method. But ensure that the caliper is well calibrated. Use anesthetic drops before the measurement, and also take the measurement under the microscope. Should not take it just with the naked eye, should use a microscope with the patient in the supine position, and then read the caliper value on a ruler. So that's the right way to use a caliper. And always validate the value of the white to white measurement using another instrument. So if you have an OBSCAN, validate it with that. OBSCAN has a feature known as the eye matrix, where you can actually measure the white to white by yourself manually. You can always check that. And if you're using IOL Master or any other of these optical biometers, then you must be cautious that these machines slightly overestimate white to white. So you should be a bit cautious in using these values, and be careful with the pterygium or pigmented areas around the cornea. They can lead to discrepancies in the measurements, and always it's important to take at least 3 readings of white to white, and both the eyes should have almost about the same white to white value. So Pentacam HR also gives you white to white here. So this is horizontal white to white value, which is provided with the in the Pentacam. You can also verify this value using the Pentacam iris image. And also the MS39, the ASOCT based tomographer that we have, can also be used for this. So this also provides the value of white to white here, and it can also be checked manually. So various tools are available nowadays. Whichever you have available with you can be used, but at least verify the values with 2 instruments. Now, the limbal sizing has been traditionally used to predict the ICL size. Now, this may be a poor predictor of sulcus size. So actually, you are placing the lens in the sulcus, but you are predicting the size of the lens based on the limbal diameter, or your white to white diameter. So which is actually not the right way to do it. So, but this is how it is traditionally done. And there hasn't been any clinically meaningful or statistical significant difference found in various studies in white to white, comparing white to white and sulcus to sulcus. So if possible, and this is the main issue for the post-operative high vaults or the low vaults, the surprises that we get with the vaults after the surgery. So if you have access to this, which is the STS UBM, it is always better to verify the size of the phakic IOL. So this is how it is being done. This is how it is being done. So you see that the machine captures the UBM, and then it gives you 10 readings. Okay, you have the 10 readings of sulcus to sulcus displayed here. You can either select the most repeatable value, the value which is coming more often, or an average of this. So one of the values, when you select the STS value, then you go to the ICL simulator, wherein you have to feed in the value of the sphere and the toric power of basically the refraction of the eye. And based on that, it would suggest you the suitable, this is basically for ICL, or it is also used for the acryl phakic IOL also. So it will suggest you the power of the lens and also the size. Now, so for this particular eye, this has given us 4 options of with various sizes. So what you can do is that you can select each option, and then what it gives you is the simulated vault. So it gives you the simulated vault, the central vault, as well as the mid peripheral vault, and then you can see which vault you want to select, and this is the predicted value. You can decide based on the vault which it is showing for the final ICL sizing. So for the power calculation, you have to go to the biotechcalculators.com, and this calculator is quite easy to use. Basically, it's quite user friendly. You just have to put patient's name, ID, date of birth, and the keratometry values, the K1 and K2 and their axis. This is the almost the last part of the presentation. So enter all the values and the preoperative sphere. So this one shows calculation for the toric lens and the preoperative cylinder. This is the manifest refraction values which you have to put here. And then you have to also enter the corneal thickness, back vertex distance, which is already 12 millimeters, white to white, and the anterior chamber depth, and then hit calculate. So once you calculate, go to the calculation, this shows the various models or options of the power of the lens. So you have to select the power of the lens, which ideally shows the least post-operative spherical equivalent. So in this case, it is 10.5, and then it also gives us the cylindrical value, and you just have to submit it. Once you submit, then this treatment plan can be saved as a PDF, which actually also shows us the rotation of the ICL toric phakic IOL. So this is the calculation sheet, which can be shared with the manufacturer, and the order can be placed. Okay, so last but not the least, preoperative counseling is extremely important, because you have to explain to the patient about likelihood of experiencing dysphotopsia, which can happen, especially with the lenses with the central hole. And there can be chances of development of cataract also, that the procedure does not prevent or treat presbyopia, has to be explained. Patients may need explantation of the phakic IOL at the time of cataract surgery. So you have to tell them whenever they develop cataract, this lens has to be removed. Also, there can be chances of need of using glasses, contact lenses, or a second procedure to fine tune or fully correct the power in very high myopes. Sometimes we also use these lenses for keratoconus patients. Now, in those patients, it's important to explain to them that the quality of vision that they're going to get with this lens will be the same which they see with glasses, but not with the contact lenses. So patients who are wearing contact lenses would expect the same type of quality of vision, which these lenses are not able to give, because the corneal irregularity can only be corrected using a contact lens. So this has to be explained to them, and a rare but potential risk of RD in high myopic individuals who have pre-existing retinal pathology must be explained to them. So in conclusion, phakic IOL surgery has proven to be a boon for patients with high emmetropia, not suitable for LASIK or SMILE, and they have been shown to be relatively safer and easier procedure in experienced hands. Of course, it's very important to perform a pre-operative planning and proper patient selection, so that we have very happy patients who are happy with the surgery. And this is all from my side. So if there are any questions, we can discuss at the end of the session.
Thank you very much, Dr. Brar. I think it's very important on this last slide to understand patient expectations, and I highly agree, especially if the patient has a corneal irregularity. And when you say on a hard contact lens or rigid gas perm contact lens, especially if it's a scleral lens, for example. But if you compare, I think, with a soft contact lens, with it's probably the majority of the patients, I think this patient should expect to have similar vision. Don't you think so? With a soft contact lens.
With the soft contact lens, they can have a similar, but of course, with the RGP lens, their vision would be better. So they need to be, RGP lens patients need to be counseled more regarding the quality of vision.
Absolutely, yes, I highly agree. So thank you very much for this great talk. We will have some questions to you, especially about the planning and the sizing. But let's move on, because we have a very exciting program. My pleasure now to introduce Dr. Siri Ganesh. who is going to talk to us about the surgical pearls on phakic IOLs procedures. And oh, we have Sri right next to you. Good
Hello,
morning.
everybody,
Good
and good evening. Thank you for inviting me to this webinar on Phakic IOL.
Thank you.
I would like to share some of my pearls in the surgery of and some tips for surgery. Let me just see if let me get my slides up now.
This is talk to you. To open it. Yeah. And now go to the screen. Share screen.
Are my slides up now? Let me just put it in.
Yes.
Can you see
Perfect.
my slides? Okay.
Perfect. Thank you.
Surgical pearls for the Phakic IOL procedure. I am a consultant to Biotech. So before we go on to the surgical pearls, I would like to talk about the design of the acryl phakic IOL so that you know the details of the lens. So basically the acryl phakic IOL has holes. It has got 5 holes, and the holes are formed in the haptic so that when the mark is on the upper left corner of the haptic structure, then the anterior side of the lens is facing forward. That means it is oriented properly. Now this is different from the ICL. On the ICL, it should be on the right hand leading haptic, but with the acryl phakic IOL, it has to be on the left leading haptic, the hole. And then you have the hole on the trailing haptic, it should be on the right side of the haptic. And then you have a central hole and 2 peripheral holes. So the 4 haptic foot plates ensure better stability in the ciliary sulcus and ease of insertion and tucking. And the advantage of the central hole in the lens is that it allows for equalizing the pressures between the posterior and anterior chamber, and there is no need for an iridectomy, and it also prevents pupillary block. It also reduces the incidence of cataract because the normal aqueous flow around the crystalline lens is maintained. So the largest and most likely particles that can occur in the aqueous are the iris posterior pigmented epithelial particles, and these particles are conical in shape and measure 16 to 25 microns and about 36 to 55 microns long. And here the central hole is about 360 microns in the acryl phakic IOLs, which is about 6 to 10 times larger than these particles, and it allows for free circulation of the aqueous. So these are the power ranges and models. They have the acryl phakic IOL is available only for correction of myopia right now, and there is no lens for hyperopia as such. So you have the models PKC 120 NH, 125 NH, 130 NH, and 135 NH. This stands for 120 stands for 12 millimeters. This is the overall diameter of the lens. 125 stands for 12.5, 130 for 13 millimeter lens, and 135 for 13.5 millimeters. So all of them are indicated for myopia. And if you look at the sizes, the size again depends upon the model. So 120 will be 12 millimeters by 6.5 millimeters. So 6.5 is the width, the total width. It's not the optic size, it's the total width of the lens. And the diagonal length is 12 millimeters. And similarly, 12.5, 6.5 into 12.5, 6.5 into 13, and 6.5 into 13 and a half. Now the dioptric range, you get it from 0 to minus 23 diopters in all the models. The optic size varies depending upon the diopter. So for 0 to 13, minus 13, you get a 5.5 millimeter optic. 13.5 to minus 16.5, it is a 5.25 mm optic. 17, minus 17 to minus 23 is 4.65, and this is the same for all the different models. The reason is because as the lens power increases, if you have the same optic size, then the thickness of the lens increases. When the thickness increases, then it can cause a mid-peripheral touch or iris chafing. You want to avoid that. You want to keep the peripheral thickness the same. So that's why the optics zone keeps on reducing as the myopic power increases. So this is a hydrophilic lens with 26% water content. It is a aspheric lens, which is aberration neutral. The maximum optic size is 5.5 mm, and we discussed it can come down for higher powers. And overall length, it's available in 4 sizes: 12 millimeters, 12.5, 13, and 13.5 millimeters. It is a steam sterilized lens, and it is designed to be placed in the sulcus. It is injected through a disposable injector through a 2.8 mm incision. The star ICL requires a 3 to 3.2 millimeter incision. And dioptric range, like I said, is it's available from 0 to 23 for the spherical lens. Coming to the toric lens, again, you have the same models: 120, 125, 130, and 135. So the sizing is the same: 12, 12.5, 13, 13.5. And dioptric range, it's available from 0 to -23 and 0.5 diopter steps. And the cylinder, it's available from 0.5 diopters to 5 diopters in half diopter steps in all the models. Again, the specification, it is hydrophilic acrylic with the UV blocker, 26% water content. The toric is similar. Everything else is the same as the spherical. So the advantage of the acryl phakic toric IOL is, as all of you all know, it is difficult to align, rotate, and manipulate a phakic IOL inside the posterior chamber of the eye with the crystalline lens in place, because the space available is very small there. So with the toric acryl phakic IOL, the advantage is there is no or minimal rotation which is required. You have to just align the lens horizontally on 0 and 180-degree axis. And the axis of all these lenses have been customized on either 0, 30-degree axis, 60-degree, 90, 120, or 150-degree in different variants. So even if you have to, if there's an odd axis and you have to rotate the lens, the maximum you may have to rotate is halfway through, which is 15 degrees. Unlike the ICL, where the maximum rotation is 22 degrees. Now, it is also found that if you rotate the lens more than 15 degrees, we know that the ciliary sulcus is not circular. It is more oval. Vertically, it is has a higher dimension than horizontally. So it is vertically oval, the ciliary sulcus. So when you rotate a lens more than 15 degrees, then what happens is the lens is in only 2 of the haptics foot plates are in contact and 2 are not in contact. And this increases the chance of the lens rotating and misaligning. So it's very important not to have a rotation of more than 15 degrees. And that's why the acryl lens has been designed in such a way so that even if you have to rotate, maximum you will be rotating it by 15 degrees. And this is how it is. You have different models. A00 toric phakic IOL, where the axis is aligned at 0, 180, 0 degrees. And then A03 is at 30 degrees to the horizontal. Then you have 60 degrees to the horizontal. Then you have 90 degrees to the horizontal, 120 degrees to the horizontal, and 150 degrees to the horizontal. So they send you an alignment sheet which shows you the placement, at what degree it has to be placed, and how much you have to rotate it. So some of the, now let's come to the surgical pearls. Intraoperative pearls. One is wound construction, then the second is loading. Loading is 50% of the surgery, and it is very important that you load the lens properly. Of course, I will show you a video of loading, but loading of this lens is much easier than loading the star ICL. And during loading, you can have a crumpled lens. And if this happens, if you see that the lens is crumpled, then it is better not to inject it, withdraw, eject it on a tray, and then reload it. You can also have a problem of plunger override, which results from inadequate hydration of foam tip plunger in an ICL. And if this happens, then the ICL will have to be removed with the injector and withdrawn from the eye. Otherwise, you can have a lens tear. With the acrylic phakic also, you can have an override of the silicone plunger over the foot plate. I'll show a video of this also. And if that happens, then you can have a lens tear. So you have to be very careful when you're loading the lens. If you're using a foam tip plunger with the ICL, then it has to be hydrated adequately. Otherwise, you'll have an override. So if you don't load it properly, this is a possibility. You can have a tone lens. So the orientation also is very important for while loading the lens, and you have to check this. Otherwise, the lens can end up upside down. So this is the correct position of orientation marks for the acrylic phakic. The leading left haptic should have the hole, and the trailing right haptic should have the hole. So this is correct. Here you can see the lens is upside down. So this is wrong, where it's on the right side. For the ICL, it is opposite. So this is, I'll show you a video of the loading. So we use HPMC, and this is a regular butterfly cartridge which you use your IOLs. So it is quite easy. You just put in the HPMC, then the lens is in BSS. So you just remove it. And here you can see that the hole is on the left side of the leading haptic. You place it with the McPherson forceps and then see that it slides easily. Then you close the butterfly cartridge, put in some viscoelastic behind. This prevents the plunger from trapping the foot plate. And then this is a front loading injector. And then you can see that the lens comes out into the plunger. I also withdraw it slightly and again inject. This is to ensure that the plunger has not snagged the foot plate. So if you are not able to withdraw, then it may be an indicator that the lens is stuck. So then we will come to insertion of the lens itself. I will show you the wound construction and insertion. So I use a 2.8 mm keratome. So you can make either two side paracentesis, but I prefer to make a single 2.8 mm incision, slightly trapezoid. And then I put in sodium hyaluronate. So that is intracameral xylocaine, 1%. And then I have my own cannula. This is the Ganesh Phakic IOL manipulator. So I inject the sodium hyaluronate. And this is the acrylic phakic. So through a 2.8 mm incision, you can gently inject it and look at the landmarks. Once you have injected it slightly, you can see the left leading haptic has the hole. Here I'm able to, with the acrylic phakic, actually the leading haptics can be inserted under the iris. You can't do that with the star lens. And this is a technique. You should not overfill the AC with viscoelastic, and then you will be able to do this. Or you can place it on the iris and then tuck it in. Here I have actually gently slid the phakic IOL under the iris, and then I'm using the manipulator to tuck in the trailing haptics. You can see that the hole is on the right hand side of the trailing haptic. This is a spherical IOL and it centers very well. So the surgery itself is quite easy if the loading is correct and you follow the. And here I'm using a high flow rate, 60 flow and 700 vacuum with IA, coaxial IA, and the sodium hyaluronate 1% comes out as a bolus. So that is the advantage of using sodium hyaluronate. It takes just about 15-20 to 20 seconds to aspirate the whole viscoelastic. If you use HPMC, then it takes a much longer time. It takes about 2 to 3 minutes. Here you can see the bubble. Notice the small bubble, how it moves around. And that basically indicates that there is no viscoelastic left behind. So then you can hydrate the wound. Form the AC, don't over pressurize the eye. And just see that there is no wound leak and the AC is well formed. So coming to the toric IOL insertion, you have to mark the 0-180 degree, do the reference marker. You have various markers. You can see this is a bubble marker. You have gravity markers, and then you have the axis marker. You can also use slit lamp assisted marking, where you place the slit at 0-180 degree, and then you ask the patient to look at the light, and this is the first Purkinje image. You see that the slit is oriented along the first Purkinje image, and then you can mark the 0 and 180 degree axis. You can also use markerless systems like the Callisto or the Varion, because this is much easier. You don't have to put any anesthetic or pre-op mark the patient. We use the Callisto system, where with the IOL Master 700, we take the image with the IOL Master 700 and use the markerless system. You can also use the Toricam mobile app to see if the 0-180 degree is marked correctly. So this is a video of the toric IOL. Like I said, this is the Callisto. We have the RTO 800 system. And this is the yellow line is the 0-180. And this lens has to be placed at 70 degrees. So here, basically, the lens is the model which is oriented at 60 degrees. So it needs like just a 10 degree rotation. So we make a 2.8 mm incision. This is with a diamond blade. And then I'm putting the viscoelastic. And this is the acryl Phakic IOL, which is injected gently into the anterior chamber. Here I'm injecting it into the anterior chamber over the iris. The previous video I showed how to inject it under the iris. Here it's injected over the iris. The whole lens is injected into the anterior chamber. Then this manipulator is actually curved so that it does not touch the central part of the lens. I tuck in the foot plates. You can see the left leading has the hole. And then I rotate it. I rotate it before tucking in the trailing haptics. I rotate it approximately into 70 degrees axis. You can see that it's aligned now. And then I remove the viscoelastic. You can see it comes out as a bolus with the high flow rate. And you can see that it is aligned, and I hydrate the wound and close the. So the other important aspect is pre-op. You need to have a very good dilatation. Ensure that you have minimum 8 millimeter pupillary size, especially when you are starting, because if the pupil is small, then you will have difficulty in tucking in the phakic IOL. If it is, this is borderline, and you can see this is a well-dilated pupil. You want a well-dilated pupil. So you should aggressively dilate with tropicamide and phenylephrine. Avoid cyclogel or cyclopentolate, because this causes the iris to be a little floppy and you don't get a very good dilatation. We also pre-treat with NSAID, so that prevents intraop meiosis, especially when you put the lens on the iris. Wound construction, you can also, when you start off, you can use 2 side ports, paracentesis, through which you can put your manipulator for tucking in. Once you are more experienced, then you can even do it through the main port. My instrument, the Ganesh Phakic IOL manipulator is available with Epsilon. So you can use that where you can inject viscoelastic at the same time to deepen the chamber when you're tucking in the haptics. This is one of the problems that you might face, and I will just show you this video. This was for a toric acryl phakic. So I put in viscoelastic. I need to orient it at 120 degrees. And now you can see I'm injecting the lens. But probably I had not loaded it perfectly or checked, withdrawn the plunger and checked. You can see that once I inject the lens is not going in fully. So one of the haptics has got entangled in the plunger. So it's not getting released completely. So I'm trying to push, but I reached the maximum, and you can see this is the silicone tip, and I actually hold the haptic and slightly I try to release it. I've released it, but what has happened is a very small part of it is still stuck. It's a very small part, but then it is not very significant. It's just in a small part of the foot plate. So I align it and I'm able to complete the case, because even if you have a 3-point fixation and alignment, then the lens is quite stable. So this is one of the problems that can happen if you are not careful while you're loading. So always put viscoelastic behind, and before injecting, you just withdraw a little to see that there is no entanglement of the foot plate. The other problem you can have is an upside down phakic IOL. That is, if you are not looked at the landmarks, or when you're injecting, if you do not inject it slowly. So some of the points are that you have to inject this phakic IOL very slowly and look for the landmarks. In the acryl phakic, it has to be on the left hand side. With the ICL, it has to be on the right hand side. If you realize that the phakic IOL is upside down, then you can retract the lens as long as part of it is still in the injector. Once you have injected it fully, then you can't. But if part of it is in the injector and then you find that the holes are not oriented properly, then you just withdraw it, the whole thing comes out, and then you can reload it and then inject it. If you have already injected it, then you will have to recover the phakic IOL from the AC through the main incision, either with a hand over hand technique using 2 forceps, or you can use your loading forceps also, and then pull it out. So this is explantation and reloading of an ICL. I have not explanted any of the acryl lenses so far. So you can see here that as the lens comes out, it rotates because it is quite thin and it has gone upside down. So once this happens, then don't try to manipulate. If you manipulate it in the eye and try to rotate it in the eye, then the chances of endothelial damage are more. So you can just slightly enlarge the wound. And that's the technique. I hold it at the optic haptic junction and then pull it out with a slight twisting motion. And then I reload the lens. This is the ICL. So I've reloaded the ICL and then I have injected it. And now it is in the correct orientation, and then I'm tucking in the haptics. That is, so always explant and then reload it. Don't try to flip the lens, otherwise you can damage the cornea. So these are, and the incidence of cataract also is more. So these are a few of the surgical pearls while doing the procedure. And I think we can take the questions at the end of the session, and we'll go on to the next presentation by Dr. Sheetal.
Yes, thank you very much. It was really, really nice. Beautiful surgeries. Adlir, when you go to the discussion, don't forget to tell us about your manipulator.
Yes.
How is it how is it designed? Because the first time I thought it looked like a little bent needle.
Yes, it's like a
doing-
cannula. Yeah, it's like a cannula, but it's like a blunt cannula. And it is sandblasted on the undersurface. So it's a little rough on the undersurface. So you can actually grab the foot plates. The advantage is that you can also simultaneously inject viscoelastic, unlike the other manipulators. So if the AC is shallowing, you can inject and then deepen the AC. So it's much easier to put it in. It also is curved. So because of the curvature, it does not touch the central part. It's not flat like the other manipulators.
Yeah, maybe if you have some figures of the cannula, of the design of the cannula, because it would be really interesting.
Um,
Yeah.
Now I
But-
don't have it here. It's available with Epsilon.
We'll check for that. Thank you very much.
Okay.
Excellent. So next talk is clinical experience with the Phakic IOL. So that's pretty much what we need to learn and what to expect and the clinical experience. And I understand you have probably one of the longest experience with this lens in the planet. So thank you again for the opportunity to learn from you, Dr. Sheetal Brar.
Thank you again, Dr. Renato. Are my slides visible? Can you see my slides?
Not yet.
Okay. So we have to. Close your presentation. Open.
Maybe you want to share your screen.
Yeah. Should be visible now.
Perfect.
All right, so I'll be talking about our experience with the Phakic intraocular lenses, and also be sharing with you the results of a comparison study which we performed between the Phakic toric IOLs and the star toric ICL. And we have the 2-year results of this study now. So this has already been discussed, the advantages of phakic IOLs over corneal refractive surgeries and refractive lensectomy for high myopia. I'm not repeating it. And these lenses, the Collamer lenses, as well as the Phakic lenses, they have been publications, and they have shown not just in the correction of spherical error, but for the cylindrical error also, these lenses are quite effective and have shown good stability with time. So this comparison study involved the first 2 models which are available, the star surgical toric IOL and the Phakic toric IOL. This was a comparison study between the 2. This was essentially a feasibility study which we started in 2017 March, and it was prospective, non-randomized, and comparative in nature. The aim of the study was to evaluate the visual and refractive outcomes with toric phakic IOLs versus the star toric ICL, the V4C model with the Centraflow technology, over a long-term period of 2 years. So the study involved 50 eyes of 50 patients with myopic astigmatism, and the patients would have had a minimum refractive astigmatism of 1 diopters to be eligible to participate in this study. 25 eyes received Phakic toric IOL implant, and the remaining 25 eyes received the star toric ICL implant. It was a single center, single surgeon series, and we also obtained institutional ethics committee approval. Now, when you compare the Phakic toric lenses with the star toric ICL, the V4C model, there is a difference in the material. The Phakic material is the hydrophilic acrylic, whereas the star material is the porcine Collamer material. The walls of both the lenses are similar. The Phakic lens is more firm, whereas the star toric ICL is extremely flexible. The rotational stability of both is comparable. When you look at the injection system, it is a comparatively easier system to use and adapt with the Phakic toric. However, with the star lens, The injection system is a bit complicated and it needs a little learning curve to understand this loading procedure and do it properly. And for the star lenses, you generally say that 50% of loading is 50% surgery done. So whereas with the acryl toric lenses, the injection system is as easy as injecting and loading a normal intraocular lens for cataract surgery. So cataract surgeons who want to start with the phakic IOL practice, I think the acryl phakic toric lenses would be they would be more convenient and comfortable with this lens. So this can be implanted through a 2.8 millimeter incision, but for the star lens, you need a slightly larger incision. Of course, the acryl phakic toric lens is less expensive. The other one is more expensive. And the acryl phakic toric lens has a spheric optic, whereas the star lens is non-spheric. So inclusion exclusion criteria were followed strictly. Again, I'm not repeating them. The treatment planning was performed using the online calculators of both the companies, the Biotech calculators.com. They also have a mobile app which can be used for calculation, and the Star Surgical online calculator. The surgical technique was also similar in both the groups because a single surgeon performed all the surgery, that is Dr. Sri Ganesh, and he used the markerless system for both the groups to guide the implantation of the toric lens. Now we published this paper which compares the surgical time and IOP spikes using two OVD devices, and this study was performed with the Star ICL, the V4C model, and we found that when we use the 1% hyaluronic acid compared to HPMC during the surgery, the spikes were significantly lower. And after this study, this changed our clinical practice completely, and we've always used 1% hyaluronic acid as our preferred OVD for any type of phakic IOL implant. So post-operatively, both groups received same post-operative medications, Predforte 4 times for 2 weeks, moxifloxacin 3 times for 1 week, and lubricants on a SOS basis. None of the eyes in any of the groups had prolonged post-operative IOP elevation, which required anti-glaucoma medications beyond 2 weeks. And the follow-ups were conducted at day 1, 3 months, 6 months, 12 months, and 24 months. So here we have the results. The preoperative comparison of both the groups. This table shows the comparison of the preoperative parameters. So both the groups were compared, and they were matched for age, sphere, cylinder, spherical equivalent, CDVA, keratometry, corneal thickness, endothelial cell count, white to white, ACD, and IOP. So you can see all the values are non-significant. So the groups were quite comparable. Looking at the results now, this is the results at the last follow-up, which is 24 months. This is what we found. This is the efficacy chart, and this shows that with the Star ICL group, the cumulative uncorrected distance vision was for 72% eyes, it was 20/20 or better, whereas in the acryl toric group, it was 76%. So almost similar. However, the acryl toric had slightly more number of eyes seeing 20/20 or better uncorrected. This is the safety profile. And we can see that none of the eyes in either of the groups had any loss of best corrected visual acuity. However, when you look at the gain, almost about 52% eyes had a gain of 1 or more lines, whereas in the Star group, in the acryl toric group, it was about 64% eyes. So we saw slightly higher gain of lines in the acryl toric group. This is the spherical equivalent refraction attempted versus achieved. Again, it shows a very good results. You can see most of the eyes in the Star toric group are within 1 diopter of correction. However, there are 2 eyes which are outside the 1 diopter range, and these eyes were under-corrected. Whereas in the acryl toric, all the eyes were within 1 diopters of SC correction. This is spherical equivalent refraction accuracy, again showing the same thing. Eyes within plus minus 0.5 diopters were 80% in Star ICL group, and all eyes, 88% eyes were within 1 diopter, because 8% eyes had a slightly higher refractive error, residual myopia it was. And for the ICRIL group, 80% eyes had refraction within 0.5, and all eyes were within 1 diopter of SE correction. This is refractive astigmatism, and in the star ICL group, 88% eyes had post-operative cylinder within 0.5 diopters, and all eyes had cylinder within 1 diopter. Whereas in the ICRIL toric, 92% eyes had cylinder within 0.5, and all eyes were within 1 diopter of cylinder correction. Looking at the stability, this is a stability chart at all the visits, and this is at the last visit you can see in the star group, it's the residual myopia. There's a slight myopic shift in both the groups, and in the star group, the residual refractive error is minus 0.33, whereas in the ICRIL toric, it is minus 0.3, almost similar, but slightly less in the ICRIL toric group. This is target-induced astigmatism versus the surgically induced astigmatism chart. And here also you can see the correction of TIA versus SIA, and most of the eyes in the star ICL group are within 1 diopter of cylinder, and this is again shown the same results in the ICRIL toric group as well, both eyes within 1 diopter of cylindrical correction. And these are the results at 24 months. These are actually results at all the visits, but I've just highlighted the results at 24 months. The visual and refractive result, it shows that the sphere, cylinder, mean spherical equivalent, mean uncorrected vision, as well as the distance corrected vision was quite comparable between both the groups. So the p-value for none of these parameters was significant, which means that they were quite comparable for these parameters of vision and refraction. And we also performed vector analysis using the Alpine's method using the ASSORT software. And if you see here, the TIA, SIA, difference vector, magnitude of error, index of success, everything is not significant. The correction index is basically how well your cylinder has been corrected. The ideal value is 1, which shows the best correction, the ideal correction. So what it shows here is 0.97 for the star ICL group, showing an undercorrection of 3%, whereas in the ICL toric group, it is 0.98, which shows an undercorrection of 0.2%. So this is hardly any undercorrection, because cylinders are always good if they are slightly undercorrected than overcorrected. So this is a good correction index that we achieved in both the groups, and they were comparable also. We also looked at the vault height and rotational stability between both the groups, and we found that in the star ICL group, the average vault reduced by 18 microns, and in the ICRIL Phakic groups, it reduced by about 13 microns on the last visit compared to 1 month vault. And the average degree of rotation from the target axis was also evaluated in the star ICL group. It slightly changed from 3.6 average degree of rotation. It slightly increased to 5.1, and in the ICRIL Phakic, it increased from 3.2 to 4.8. However, the degree of rotation from the target axis remained within 5 degrees in both the groups. Changes in endothelial cell density, there was a slight drop after 2 years. However, the changes were not statistically significant in either of the groups. We also evaluated post-operative total higher order abrasions and whole eye MTF at the last follow-up using the eye trace abrometry. And what we found was that the total higher order abrasions, the RMS of the higher order abrasions in the star ICL group was slightly higher. So it's 0.33 versus the ICRIL Phakic toric group, where it was 0.29. So the abrasion was slightly lower in the ICRIL Phakic toric group. However, the difference was not statistically significant, and both the groups had acceptable abrasions, which is normally considered to be within 0.5 microns. So they were within 0.5 microns, so which is quite comparable. And on the other hand, this whole eye mean height of MTF was also evaluated, and we found that the ICRIL Phakic toric IOLs had slightly better MTF. Again, this difference was not statistically significant. And looking at the patient satisfaction scores, we asked the patients to evaluate their spectacle independence on a scale of 0 to 10. This was at the last visit, 8.8 for the IQL Phakic group, and for the star group, it was 8.4, very similar. And the dysphotopsia symptoms were also quite comparable. With the Phakic toric group, it was 0.7. And for the star group, it was 0.5. Initially, if you look at the score of both the groups, it was higher, 7.4 and 7.8. However, at the end of 2 years, it was minimum, less than 1. And the overall satisfaction score was also comparable, 97.6 for the IQL Phakic toric group and 96.2 for the star ICL group. Long-term complications, none of the eyes in the IQL Phakic toric group had any of the vision-threatening complications such as secondary glaucoma, prolonged inflammation, and they did not require any resurgery. However, in the star ICL group, only one eye of one patient required re-rotation of the toric ICL due to significant rotation, post-op rotation, and 2 eyes of one patient required exchange due to the high vault. So to conclude, both toric phakic IOLs exhibited excellent safety, efficacy, stability, and rotational stability in the long-term results seen at 24 months in the study. Vector analysis of astigmatism showed a mild undercorrection of astigmatism, which is actually desirable. Dysphotopsia complaints were initially reported, however, they decreased with time and the patients were comfortable later. And spectacle independence and patient satisfaction scores were also comparable. Hence, we can conclude by saying that the Indian manufactured phakic IOL lenses may be good or rather an excellent option and a much more affordable option for patients who require phakic IOLs. And these lenses are also easy to adapt surgically for most of the cataract surgeons who want to begin with the phakic IOLs. These were the results, and I hope we can take some questions about the study at the end of the session. Thank you.
Thank you very much. So we have one more talk from Sri Ganesh on dealing of complications. And I saw on the last slide that we had 2 cases that they have to exchange the lens. Is that correct?
Yes. This patient had high warts, and we did a UBM also and found that the sulcus to sulcus was actually smaller than the white to white. It was an anatomical abnormality, and we need to exchange these lenses because the walt was.
I hope you're going to comment on those cases probably in this next talk, right?
Yeah.
Excellent. So thank you again. So let's go to the talk, and then we go for the good discussions that we have for the next.
Yeah. Is it visible now? Is it visible? Are my slides visible now?
Yes, sir.
Okay. So let's look at dealing with post-op issues with phakic IOLs. So there are early post-op, late post-op, and atypical complications that can happen. The early post-op complications include IOP spike, pupillary block, angle closure, high vault or a low vault, and traumatic or iatrogenic cataract. The late post-op complications include glare, halos, iris transillumination, cataract, glaucoma, and the long-term. Sorry, I need to just plug in the laptop. Battery is. Yeah, and the atypical long-term findings include pupil ovalization, iris transillumination, and pigments on the lens. Coming to the early IOP spikes, this is something that can happen because of retained viscoelastic or over pressurizing the eye. So we normally ask the patients to stay back for about 4 hours, and we check the IOP with NCT every hour. And if the IOP is more than 24 millimeters of mercury or more than 10 millimeters of mercury higher than the pre-op, then you may have to take some action. Most common cause of these spikes are because of incomplete viscoelastic removal. The other aspect is pupillary block. If the viscoelastic or an air bubble blocks the central hole, then you can have a pupillary block and an IOP spike, and also you can have a high vault. So very important to avoid this complication is careful and thorough removal of viscoelastic, and you can use 1% hyaluronic acid, Helon or any other equivalent. We also did a study comparing the surgical time and IOP spikes by using two visco surgical devices. One is HPMC and the other was sodium hyaluronate with the STAR ICL, and this has been published also in clinical ophthalmology. And we found that using the HPMC again took a longer time to evacuate the HPMC, almost about 2 to 3 minutes compared to the sodium hyaluronate, which took just about 15-20 seconds, because it comes out as a bolus and you can aspirate it through the central hole also. And we found that the IOP spikes post-op also was less when we used sodium hyaluronate, because it gets evacuated as a bolus. So coming to treatment of the early spike, 24 to 48 hours, in the older lenses without the central hole, it was very important to check the patency of the PI, but that is not a problem now with the central hole. But if the IOP is high because of retained viscoelastic, the simplest thing is that you can burp the incision, either the side port or the main incision. It's better to burp the side port if you have made a side port. So under topical anesthesia, you can just take a 26 gauge needle, and on the slit lamp, you just press on the posterior lip of the paracentesis and then release a little bit of aqueous, and that would basically bring down the IOP. You can also...
It was some dark, so now it is good, sir. Thank you, sir.
You can also... Is it okay?
Request to you, who is from the IPCA team, just please mute your camera and stop your mic, stop your camera.
Okay, you can also use IOP lowering agents like Dimox and any topical anti-glaucoma medications. And depending upon the situation, you can either constrict or dilate. If you think that the vault is high, then you can even constrict the pupil, and this may actually open up the angle and increase the evacuation of the aqueous. Or sometimes if you think that there may be, I had one case of malignant glaucoma. So if you suspect that, if there is no pupillary block and if the AC is shallow and the IOP is very high, then you need to put in atropine, dilate the pupil, and give mannitol, and then it will settle down. The other thing is you can just take up the patient again and do a thorough irrigation aspiration and remove all the viscoelastic. And you can treat it similar to your cataract patients with intraocular lens implant who have the same kind of problem. The other problem is when you can have refractive surprises with the power, and this can occur because of data entry errors. So while doing the calculation, it's very important that the data has to be entered correctly, and you should not include the corneal thickness in the ACD field, because sometimes the OpScan, if you're using the OpScan, it gives the ACD along with the corneal thickness. You'll have to subtract the corneal thickness, and also you'll have to ensure that the back vertex distance when you're doing the refraction is correct. And when you're starting off, you select patients with at least 3 millimeter antechamber depth. And once you're experienced, then you can even take up patients with 2.8 mm ACD. The back vertex distance is very important, and the software uses a default of 12 millimeter. So when you're doing your refraction, ensure that the back vertex is 12 millimeters. Otherwise, when you're refracting high myopes, you can get surprises. And if you use a different back vertex, then you'll have to change the default in the software. The other aspect, very important aspect, is sizing. And to minimize the risk of over or undersized phakic IOLs, accurate pre-op measurements of white to white and antechamber depth need to be done and entered into the online calculation software. And both values are taken into account to determine the correct size of the phakic IOL, and follow the Biotech surgical guidelines. And then your oversizing or undersizing issues would be less than 1%. We use a UBM here in our pre-op evaluation to also check the sulcus to sulcus, and we compare that along with the white to white, and then take a decision, because sometimes you can have abnormalities, anatomical abnormalities, where the sulcus is much bigger than the white to white or even smaller than the white to white. Post-op, you will have to look at the vault, and you can assess the vault by using your slit lamp. The ideal size phakic IOL vault should be, if you look at the vault is the distance between the central anterior surface of the crystalline lens and the posterior surface of the ICL. Generally, an acceptable vault is 250 to 750 microns. And you can compare that to the slit of the corneal section. Sorry. And it should be at least either half corneal thickness to 1.5 corneal thickness. You can also look at the vault with the ASOCT, and you can measure it also. You can see here it is 491, which is a normal vault. An oversized phakic IOL, which is more than 1000 microns vault, may push the iris forward and then close the angle. And this can lead to an IOP rise and iris misfunction also. The acral phakic IOL sizing, the vault again with the, here with the ASOCT, you can see that there is a very high vault, and you can see that there's a slit-like angle, and it's almost getting opposed, and then this can give rise to an angle closure glaucoma. Also, if you have a very high vault, it gives rise to pupil ovalization. You can see here that the pupil has become oval, and the pupil size also increases. When the pupil size increases because of high vault, you can have night vision problems and dysphotopsia. So if you have a very high vault, more than 1000 microns, then first thing you can do is, if it is just a spherical phakic IOL, you can look at changing the orientation from horizontal to vertical. The other option is to exchange with a smaller size phakic IOL if changing the orientation does not work. And you cannot change the orientation in case of toric phakic IOL, so you will have to exchange it for a smaller lens. And this is a paper showing direct measurement of the ciliary sulcus diameter by ultrasound biomicroscopy, and it showed a mean difference between the vertical and horizontal diameter of about 0.67 millimeters. So this is again very significant, because the white to white is oriented horizontally. So the horizontal white to white is the maximum, whereas with the sulcus, the vertical sulcus diameter is the maximum. So this is management of a high vault. This was a 21-year-old female with refraction of minus 9.5 cylinder, and the left eye also was minus 9.25 with 1.25 cylinder. And we used a spherical ICL. Both eyes 13.2 millimeters, power was minus 10.5 and minus 11. Uneventful ICL surgery. And day 5, patient came for routine follow-up. Clinically, there were high vaults. Right eye was 1.29 millimeters and left eye 1.24. So you can see that was the ASOCT 1.29 and 1.24 in the left eye. So we took up this patient for reorientation. So put in xylocaine 1%, preservative free, and then a little bit of viscoelastic on top of the um, ICL, and then rotated it to bring it into the vertical position. So this was done. And then we just washed out the viscoelastic and then hydrated the wound. And a similar thing was done for the left eye. This is the left eye, you can see that we just put in the viscoelastic and then rotated it gently to orient it vertically from horizontal. And then you can see the visco comes out as a bolus. And you can see the post-op, the vault reduced to 782 from and 857. So there is almost 200 microns decrease in the vault. And this is a simple trick that you can use for correcting high vaults. An undersized phakic IOL with a vault less than 150 microns may increase the risk of anterior subcapsular cataracts. Here you can see that it's a very low vault, it's almost touching. And sometimes center also, they may be about 100 or 150 microns difference, but there may be a peripheral touch. So it's very important you dilate and do a ASOCT, or you can even use the UVM and then assess the peripheral touch also. And for phakic IOLs with a center hole, if you have a vault up to 100 microns or more, you can observe it. But for vaults less than 100 microns, you perform a UBM, STS measurements, and then you may have to exchange it. You may have to increase the size by 1 or 2 steps, depending upon the STS. The other problem you can have is traumatic cataract. This happens mainly because of reduced working area. You can see this is once you remove the crystalline lens in cataract, you have a much larger space. When you have to work in a phakic eye, then the space is much smaller. And touch of the crystalline lens when you're manipulating the phakic IOL can result in an anterior subcapsular cataract. And anterior subcapsular cataracts that usually occur within 6 months are considered iatrogenic. And you can avoid this by using the paracentesis. When you start off with phakic IOL surgery, you can use the paracentesis to manipulate the ICL or the phakic IOL, and don't cross the optical zone and do not press on the optic. The other issue you can have is phakic IOL misalignment. It's not post-op rotation, but misalignment during the surgery. This can be because you have not marked the 0-180 degrees pre-op. So you'll have to focus on pre-op marking of the 0-180 degree or the 6 o'clock as a reference. And this is quite rare, reported 1 in 100 cases, mainly because the surgeon has not aligned it properly. And it is noticed on day 1 because of poor visual acuity. You will have to realign the lens. This is an example you can see here that immediately after surgery, this is at 1 week, the refraction is mixed astigmatism with loss of best corrected vision. I mean, loss of uncorrected vision is not good, but the best corrected vision is 20/20. But after realigning it and rotating the ICL, then you can see that the refractive error has come down and the uncorrected and best corrected vision is similar. I'll just show you a video of ICL rotation. You can see this is a ICL which had rotated post-op. So you can get post-op rotations because of IOP increase or undersizing of the lens. So here I'm realigning the lens. I go in through the paracentesis side port, put in viscoelastic, and then use the manipulator to gently rotate the lens. You don't touch the central optic, but you can just manipulate the lens with the haptics and see that it is reoriented in the proper axis. And then you can recheck with the Mendes marker and see that the lens is stable. The other problems you can have is dysphotopsias. Normally, what you get is um, the glare. This is glare, this is halo, starburst, and ring-shaped dysphotopsia. So normally with the phakic IOL, with the central hole, you can get glare and you get the ring-shaped dysphotopsia. And patients actually draw these diagrams when they come initially and say that I'm facing this problem. It could be because their pupils are very large, or even if you have a high vault, this expands the pupil, and you can have from the edge of the phakic IOL, you can have this dysphotopsia. You just have to kind of reassure them and it goes away in time. If it is oversized, then you may have to exchange the lens, or you can even give them alpha GAN. Cataract can occur because of a low vault. You can get a anterior subcapsular cataract. Mechanism is intermittent or constant contact of the phakic IOL with the lens. It also alters the flow of aqueous and compromises the nutrition to the lens. When the patients accommodate also, there may be a forward shift of the anterior pole of the lens and intermittent contact between the ICL and the lens. And this over a period of time can give rise to an anterior subcapsular cataract. The US FDA, in its study of the ICLs, without the hole reported about 1.3%. If it's less than 0.6%, if it's more than 0.6%, it is significant. However, incidence of cataract in phakic IOLs with a central hole, there are two publications. One is on the ICL and the other is on the ICRIL. And in both of them, the incidence of cataract formation was practically nil. So with the central hole, with proper nutrition to the lens, the incidence of cataract is very low. If the patient develops cataract, the management, if there are lens opacities without involving the visual axis or affecting the best corrected vision, then you can just observe. If the cataract is significant, affecting the visual acuity, and patient has glare, then you may have to remove the phakic IOL and do the cataract surgery with IOL implantation. You can do it either manual, or this is with the femtosecond laser. This is an interesting case. And with the femtosecond laser, you basically have to, it identifies the phakic IOL as the anterior surface of the lens, and then manually you will have to shift that down to the anterior capsule before proceeding with the capsulotomy and nucleotomy. Otherwise, it makes the capsulotomy on the lens. So this is you can do the capsulotomy and the nucleotomy. So once that is done, then you take up the patient, 2.8 mm incision. And here, this is the ICL. I hold the optic haptic junction, and with a twisting motion, I'm able to remove the ICL to the 2.8 mm incision. Then you can proceed. These nuclei are usually quite soft. This is my technique of viscochop, where I inject viscoelastic into the nucleotomies to split the nucleus. And with a one-hand technique, just remove the 4 fragments. IA is performed, and this patient had a very high myopia, so I'm using, I think, a minus lens. This is a 3-piece Acrysof IOL.
How long after surgery
Yes.
this patient developed cataract?
This patient, I think, was, I think, about 5 years, but this was without the hole. So without the hole, the incidence of, I have done about 7,000 ICLs. From 2012, I've been doing, 2002, I've been doing ICLs. So about 7,000 ICLs, and I think I have operated about 18 of these for cataracts, but almost all of them were without the central hole. So the other problem you can have is post-op glaucoma. This can be because of persistent uveitis, or you can have this because of sizing issues, incorrect white to white or parallax, or not using calipers to measure. And also you can have this because of patients' abnormal anatomy. So oversized phakic IOLs can either cause a pupillary block. Now with the whole pupillary block is not so much of a problem, but it can push the peripheral iris forward and then cause a angle closure. This is phakic IOL management for a high vault. So this is the exchange that we did. So this patient had 13.2 mm lens, which was planned, and you can see the vault was very high and the angle was very narrow, even on UBM. So we exchanged it with a 12.1 mm. So almost we went down 2 sizes because the vault was very high. This is how I exchanged the phakic IOL. So I 2.8 to 3 mm incision, then just push the lens forward. It comes out into the anterior chamber, put in viscoelastic, rotate the lens slightly so that you can grab it at the optic haptic junction. That is where it is thickest. I go in with the loading forceps, grab it at the optic haptic junction, twist it around, and then it comes out easily. Then this is the lens, which is 2 sizes less, 12.1 mm. And then this was the patient who sulcus was much smaller than the white to white. So you can have abnormalities in the anatomy. The lens is centered well. And then we remove the viscoelastic. The post-op vault. And then the post-op vault was normal and the angle opened up. So you can see the post-op vault was 406 and the angle also is opened up. And this was the clinical photograph. The atypical long-term findings include decentered phakic IOL. Sometimes if you have zonules which are broken, you can have this kind of a decentration. 1 year post-op, this is ICL decentration noted, and you can reposition it at, you rotate it at 90 degrees and you can see that it is well centered. So that is something you can do. The other problem you can have is iris transillumination 2 years post-op, especially in high vault. You can have pupil ovalization and constant friction of the phakic IOL implant with the posterior surface of the iris, and you can get some transillumination. But it is rare. The other problem is pigments on the phakic IOLs. Because of high vault or peripheral touch, you can have some pigments, but these do not usually affect the visual acuity. So those are some of the complications and how to manage. And I think we can go on to the discussion because we have, I think, about 20 minutes now.
Excellent. Thank you, Dr. Ganesh. Thank you, Dr. Brar, for your great presentations. We have learned. And then my first question to you, and we have Dr. Mayumi and Dr. Bruno Fontes here with me. My first question is on how you approach the bilateral surgery. You do one eye at a time. What's your routine for that? That's the first thing that comes to my mind.
For phakic IOLs, I do bilateral surgery because I have the RTO and I have an integrated OCT. So the main issue with the ICL is sizing. Why you want to defer is that you want to assess the sizing after you put in the lens, because if there is any difference in the sizing and you have a very high or low vault, you can adjust the other eye and exchange this. But since I have the RTO, I've got the intraop OCT, I actually can look at it intraop and I know the vault. So I prefer to do bilateral surgery, and I do bilateral surgery. I do one eye and then I do maybe a case of cataract, and the instruments, everything are changed, and then I do the second eye, like a second surgery, but on the same day. This is because patients also prefer that. As most of them whom we advise phakic IOLs eventually come in for LASIK or SMILE, then we find that the corneal thickness is not adequate or the refraction is high. They're not suitable candidates. And they want a similar experience as corneal refractive surgery. And most corneal refractive surgeries done under topical, it takes about 15 minutes. Day care procedure, bilateral. So this experience for the patient is very similar to corneal refractive surgery. So that's why we are also happy to do bilateral surgery.
Also because we do the STS measurements, that has also improved our accuracy in terms of the ICL sizing. So we have not faced any issue with the ICL sizing.
For the acryl phakic, we have not exchanged a single lens.
Yeah.
Because I think the diameter of the acryl phakic is different from that of the ICL. And I think the measurements are more compatible with the sulcus because they have a 13 millimeter lens, I think, which 12.5 and 13 are the maximum ones that I used.
Interesting. You mentioned a measurement, which is S to S measurement. Is the UBM that you're talking about?
Yes, UBM is with the sulcus to sulcus measurement.
Oh,
we use the
STS.
quantil, but you can also use the arc scan. So I think Dan Reinstein has done some nice work studies on using the
very high frequency
arc scan and then
yeah.
Just interrupting, but taking advantage of the discussion. Dr. Shida said on her presentation that she measures the white to white in different devices. But what is the final the final white to white value that you input in your calculation? Is the STS or is the white to white taken from the Orbiscon, for example?
So in the calculator, you have to use the white to white. STS, the sulcus to sulcus, is only for the ICL sizing. Basically, we want to see whether the sulcus to sulcus correlates with your white to white or not. Because traditionally, the white to white is used as a surrogate for STS measurements. Now, basically, your phakic IOL is placed inside the sulcus. So ideally, you should know the sulcus measurements because that's where it's going to be positioned. However, it is not possible to measure the sulcus with the topographers that we have. So you need a UBM for that. Okay, so yeah, so that's why we just want to verify. We do the white to white with at least 2 instruments. We also have the OBSCAN, we also have Pentacam, we also have the caliper. So we verify with the caliper and either the Pentacam or OBSCAN, and the value most of the times it is very close, but sometimes there can be discrepancies if the machine, especially your topographer, is not able to delineate the boundaries of the limbus clearly. So say if you have a corneal, say peripheral thinning, or you have a pterygium or a scar, so then you need to go into the software and calculate it manually, and also verify it with the digital caliper under the operating microscope. So that would be more reliable in these cases.
In practical terms, so you consider the white to white from one device, even having measured in 2 or 3 different devices, and you do the STS measurement just to verify if the size of the lens in the calculator is something similar to the.
It gives us the simulated vault.
See, what happens is there are some outliers where the white to white does not correspond to the sulcus to sulcus. These are outliers with anatomical differences, like the last case I showed you where I exchanged the lens. Patient had a very high vault. The sulcus to sulcus measurement was actually less than the white to white. And I ended up getting a very high vault, more than 1000 microns with a slit-like narrow angle. So I had to change it. So these are surprises that you can avoid if you do a UBM and also check. So your incidence, normally the incidence of lens exchange is about 1%, 1 to 2% because of the wall changes, either very high or very low wall. You can reduce this if you do a UBM, but right now there is no perfect formula. But the advantage of the ICL is you have a very wide tolerance. So you can have a vault anywhere from 250 to 750, which is acceptable. So 200 to 800 also is acceptable. So you have a very large range, which is normal vault. So that is the advantage. But even with that, there are a few cases, outliers. So if you have a UBM, you can reduce the outlier.
There are very interesting questions coming from the forum. I just chose two of it. Have you any experience using this IOL as an add-on IOL like the Sulcoflex for correcting refractive surprise after cataract surgery?
Yes,
and the other question, interesting question, is have you experience in using that IOL in keratoconic patients?
See, I prefer to use a phakic IOL rather than the Sulcoflex, because initially I was using the Sulcoflex. One is the Sulcoflex has very large haptics and sometimes they get stuck and torn. And I've had this experience, and it is much more expensive, the Sulcoflex, especially the toric Sulcoflex with the high cylinders. So I have used Icryl in I think 3 or 4 cases as a piggyback lens, and it works very well because it's based on the refraction, the measurement of the lens. So it works very well, and you can definitely use it as a piggyback lens, and it works well. For keratoconus, yes, we use phakic IOLs for keratoconus. And only thing is that we see that the best spectacle, best corrected vision has to be better than 6/12, better than 20/40. If it is worse than 20/40, then we don't recommend ICL as the first procedure. We may probably do a TopoLink PRK with cross-linking to kind of improve the corneal surface, improve best corrected vision, or we can put in intracorneal ring segments to improve the BCVA, and then better than 6/12, and then put in a phakic IOL. But phakic IOLs are excellent for keratoconus. The only thing is that you'll have to tell, most of these patients are using rigid lenses, rigid contact lenses, and they would expect the same kind of vision after the phakic lens. But you will have to warn them that the vision will be similar to that of a soft contact lens or their spectacles, because the corneal irregularity is not corrected. So we either put in phakic IOLs after doing a cross-linking, wait for about 6 months after cross-linking, and then put in a phakic IOL. Or sometimes if it's a milder keratoconus, axial keratoconus, then we do a TopoLink PRK with cross-linking, and then after 6 months put in a phakic IOL. Or eccentric cones, we put in intracorneal rings with cross-linking, and then put in a phakic IOL. So there are a lot of combinations which you can do, but phakic IOLs definitely has a place for treating keratoconus.
It's always better to stabilize the cornea first and reduce its aberrations as much as possible, either by doing topo-guided treatments.
Yes. Going back to the original question about the UBM. One of the things that we always debate is, are we able, or should we do the posterior chamber phakic IOLs only with white? I know it's possible because the calculator allows you to. So what would be your recommendation? So every case should have it just to reduce the outliers, and you talk about 1%. And now you're adding a second topic for this armamentarium to reduce problems, which is the intra-op OCT measurement. With the OCT, first question with the OCT, which is more practical, have you had to change the Icryl lens on site because of what that measurement can give you that you have used that made a real difference for your patients?
See, intra-op measurement with the integrated OCT, if you're doing bilateral surgery, you put in a lens and you find that the vault is very high, then you can basically remove the lens, and then reorder another lens. Don't do the other eye. And that is the—
Has it happened?
No, so far with the Icryl, we have not had any surprises. We have not exchanged any lenses. We have done over 200 lenses with the ICRL. Of course, as numbers go up, then definitely statistics catch up. But right now, but with the star, of course, our exchange rate is about, it's less than 1% now because we're using the UBM. But even with the UBM, again, it is not perfect because we just look at the sulcus to sulcus. But the other important factor is the lens raise. The lens raise also would determine the vault, and different patients have different lens rises. That is your a line drawn from the sulcus to sulcus, and which passes through the crystalline lens to the apex of the crystalline lens. That is the lens rise. So if the lens rise is high, you will have a lower vault. If the lens rise is low, you may have a higher vault. But how the RTO also helps is, even sometimes, even if you have a large vault, if you have a low lens rise, you have a large vault, but then you have an adequate, you can also look at the angle of the eye, and with the RTO, and if the angle is open, sufficiently open, even if you have a large vault, then it does not matter. You don't have to exchange the lens. So the UBM is not 100% necessary. You can just use calipers. You can take 3 readings with the calipers and then do it. And in about 98% of the cases, it's going to be fine. But if you want to improve it to say 1.5% more, then probably a UBM will help.
There is another interesting question right here. Sometimes biocompatibility of the materials are an issue. And one easy way to see that is when we have a lot of pigment deposition in the material. So the question is, how is it possible to differentiate, or when to differentiate problems with biocompatibility with maybe problems with excessive lens movement causing rubbing of the iris and releasing pigment?
Usually biocompatibility is not a problem, because what we have seen is both with the ICL and ICRL, the lens is very well accepted. The incidence of iritis is very low. But if you have a high vault, then you can have rubbing, pigment release, secondary glaucoma because of pigment release, persistent uveitis, and transillumination. But it is extremely rare, extremely rare. So if you have a very high vault which is causing pupillary dilatation and rubbing of the iris, then you should immediately exchange it. If you leave it for a long time, then you can have these problems of iris transillumination, secondary glaucoma, pigmentary glaucoma.
So essentially, it's the vault due to which you can have pigment release due to the constant rubbing, and not the material.
Also, the quality of viscoelastics used.
Yes, about the viscoelastic, I see you use methylcellulose for the cartridge,
Yes.
but you recommend to use hyaluronic acid inside the eye. That's exactly what you do it in all cases.
Yes.
And you don't use things to reduce the size of the pupil intraop as well.
No, because if you use myotics intraop, the patients can have some discomfort and then headache post-op, and it is not required. It was required for ICLs without the hole. When you had to do an iridectomy, intraop iridectomy, then we used to constrict the pupil and do the iridectomy. But now with the hole in the center, you don't need to do the iridectomy. So you don't have to constrict the pupil.
That's very interesting, because we saw a very nice webinar on phakic IOL sizing, and that was one of the main recommendations that was across the real experts. A lot of people were still reducing the pupil, and all the problems that can come, the many problems, including the vaulting change. It changes. It does change. I never thought about that. One thing that comes to my mind, I don't know if you've seen a film from Japan, from Dr. Turi, on the violet light block. Do you know about the violet light block from this lens? Because they compare the anterior chamber IOLs. One has the block, the other does not have the block. If you have the block, you can have more chance for having an elongation and progressive myopia?
It is basically progressive myopia in the pediatric age group. But we generally, we generally do the phakic IOLs in patients over 21 years. And so far, the stability has been quite good. Progression of myopia is not that much. Because if you look at even regular glasses, regular plastic glasses also have UV blockers. So if you're wearing glasses also, then it blocks the UV violet light. Of course, these have some inbuilt UV blockers. All lenses, including intraocular lenses, have some amount of UV blocking.
Yeah, this is interesting because they did this IOL comparison on patients that received the IOL. So they are all not real pediatric. They are young patients, but not older than 18, 21 years old. And they compared the rate of progression on high myopia in adults that received the foldable IOL, the more flexible IOL, and the non-flexible IOL, and the change was significant. It was a small sample size, of course, but this is something I'd like to. Do you have information about the profile of the blocking of the UV and violet light for the ICRIL?
ICRIL has UV blockers, but I don't know the range.
Okay,
I think the company can kind of.
that's an interesting point because we see this progressive myopia as a problem for many adults as well.
I think it blocks UV in the lower range.
So that's
But
the
it does
ideal
not
one.
completely block all UV rays. But I think the lower range, but I'm not sure of the range. I think Mr. Khalsa can kind of clarify from.
Yeah, in case of ICRIL phakic, it filters up to 440 microns, which is slightly above the UV range. So even the slightly violet part of it.
430 nanometers.
Yeah.
Excellent. So one other question is about the glaucoma, the malignant glaucoma, as you said. And the malignant glaucoma is a true real malignant glaucoma that you have aqueous going to the vitreous.
Yes.
Can you comment? It was only one case that you had, and you just dilate.
There was only one case with the ICL that was many years ago. It was without the hole, the ICL without the hole. And immediately after the ICL surgery, first post-op day, I saw that the AC was almost flat. I'd done an iridectomy. The iridectomy was patent, but the IOP was very high. The AC was almost flat, and
The vault was normal.
yeah, vault. No, the vault also was low. The AC was almost flat, and then there was no pupillary block because the iridectomies were patent. And then I kind of put this patient on atropine and then immediately gave IV mannitol. And then after a few hours, the IOP came down. We didn't have to do any surgical intervention. He's okay. He's doing well. The IOP is under control, but the only thing is there is some amount of mydriasis now because of the high IOP, persistent large pupil and night vision issue, but I think he's got used to it now. So I think this was about 8 years ago or something like that. I had only one eye going in for his other eye was normal. So he had only one eye which had a flat AC.
I see you get the patient waiting for 4 hours to check the IOP in the same day.
Yes.
And do you use any oral medication for reducing the IOP spike, or just what's the routine?
First choice would be burping the incision. If there's some retained viscoelastic, I burp the incision, and that lowers the IOP, and then we watch for some time, maybe another couple of hours, and if it's normal, we discharge them. You can also put them on oral medication, Dimox, to reduce.
But do you use it as a routine? The acetazolamide?
We don't use Dimox as a routine. No, acetazolamide is not used as a routine.
We don't use it as routine. We observe patient for 4 hours, and if during these 4 hours patient's pressure is more than 30, so then we do prescribe acetazolamide, once stacked and once for the night time, and we also observe the pressure on the next day, and usually it's okay after 24 hours. But if patient still has, then we may have to continue the oral medications. And it's very important to differentiate the IOP rise immediately from steroid response also, because most of these patients would be responders, steroid responders.
Um negócio.
Sometimes, sometimes we see the steroid response as early as 2 days. So that is something you have to keep in mind. We normally call them at 1 week for a checkup, and quite a few of them are steroid responders because they're high myopes, and you can have a steroid response and you see a steamy cornea. IOP is quite high. So normally we put these patients 4 times QID for 1 week, and then put it twice a day for another 1 week, just 2 weeks on topical drops.
Or we switch to a lower potency steroid like lotipred.
Dr. Chita, I have one last question. It's about the spherical aspect of the lens. I was giving a lecture on phakic IOLs earlier this week, and then I was asked about this, and I was very surprised to see that the ICREL has a spheric profile. I don't remember the amount of the spherical aberration of the lens. Do you know what?
Zero aberration.
It doesn't have abrasions. It's not
very nice.
aspheric, but without abrasion.
Aberration neutral aspheric lens.
Yeah, very interesting. Yeah, thank you.
Dr. Neto, you have to unmute your mic.
Have you had any surgery, retina surgery need for this type of patients? For example, patient that had a retinal detachment, that did a vitrectomy, and experience with that?
Yes, we have had a few patients. We prefer to, if possible, just do a buckle. If it is not adequate, if the tear is large, or sometimes if it is complicated with proliferation or a large tear, then vitrectomy is needed. Most of these patients, after silicone oil, develop cataract, then we will have to go in and then remove the ICL and do a cataract surgery. So by and large, we prefer to just do an external procedure like a buckle if possible. All these patients are evaluated by the retina surgeon with indirect ophthalmoscopy and indentation pre-op. We also take as consent because there is some incidence, maybe about 5 to 6% incidence of RD once you open the eye in these high myopes. So that is a possibility, and we tell them about that. Yeah, IOP changes, decompression. And at 2 weeks, again, we check the retina, and at 3 months. And we recommend a retinal examination every 6 months, or SOS immediately if they have any symptoms of flashes of lotus.
So today, the question is, you have a patient coming for phakic IOL. How you choose? Let's say you have a patient, a -9 patient with 25 years old. He has a kind of a okay cornea for doing a smile, considering topography, tomography, whatever you screen. And how you decide what is best for the patient? What is your? Can you give us a hint? Because there are some cases that we cannot go to the cornea, and this is kind of easy. You go for the phakic IOL. But in this range, where you go for the phakic IOL?
Generally above 8 diopters of myopia. In a younger patient, I prefer to do a phakic IOL. If the patient is older, above 32, 35 years of age, -9, adequate corneal thickness, you can still go ahead and do a corneal procedure like SMILE or LASIK. But if it's a younger patient, maybe if it's a 22-year-old with a -9 or -10, then I would still prefer a phakic IOL even if the corneal thickness is adequate. Because these are patients which are at higher risk of ectasia because you have to remove a lot of tissue. Plus, the quality of vision is not that good. You'll have to use a smaller optical zone. And the risk of regression is more. With phakic IOLs, there's no regression. You might have a slight progression of myopia, but when we look at the stability, the phakic IOLs have the best stability. They have better contrast than most corneal refractive procedures. There's also 60% of them, of the high myopes, have improvement in BCVA because of the magnification factor. So these are all the plus points. Night vision is better. So these are all plus points for using a phakic IOL.
So we can always expand the limits. We can always push the limits. We can do smile extra and things like that. But the thing is that we should always have in mind the overall the results, the patient satisfaction, and the long-term outcome which the patient is going to have in terms of quality of vision. Because invariably you'll be using a very small optical zones. Patient will have post-operative glare, dysphotopsia, aberrations induced will be much higher, quality of vision will be compromised, and also we are exposing the patient to the risk of ectasia,
And also,
especially a younger patient.
Also dry eye. Dry eye is a big issue with corneal refractive procedures. With phakic IOLs, you don't have significant induced dry eye. So that's a very big point. The comfort is much better. The patients are much more comfortable. They see better. The stability is better. And definitely when you compare the complications, ectasia or cataract, you would definitely, cataract is much easier to manage than ectasia. We can't hear you. You'll have to unmute. Yeah.
Oh, it's not so simple because of the retina, but I agree with you. Ectasia is still a conundrum, and we have to. And phakic IOLs is a way to prevent. And two things to prevent ectasia: stop rubbing and do more phakic IOLs. But when you start doing phakic IOLs, what's the minimal level of correction that you go for the phakic IOLs? Maybe that's the question for you.
I have corrected even 3 diopters of myopia. Very thin corneas, a keratoconus.
Okay. Okay, but for a non-keratoconic cornea, let's say you would say this is the level of myopic correction that I will go for the phakic IOL. -5, -8.
-8 and above, definitely. But if the patient asks me even above -6, yes, phakic IOL. Some of them come in, their friends have had phakic IOL, and they're very happy. They ask for a phakic IOL.
And today your routine is doing ICRIL. You still do phakic IOL with other options that you have on the market?
Yes, ICRIL, I use both the ICL and ICRIL, but nowadays I'm using more of the ICRIL because I find that the results are as good. We did the study also, and it shows that the results are quite good, and we have a 2-year follow-up. So yes, definitely. And for the patient also, it costs a little less than the ICL. We get it faster because, and the rotation is less than the ICL. So these are all a few of the advantages.
Yeah, the issue of the cost is very important. What you want to comment on that to Dr. Fontes and Dr. Mayumi?
Mayumi first. The issue of cost, it's really a problem here in Brazil. But no doubt that for higher corrections, the fake IOL can provide better quality of vision, and maybe became the first choice for high correction, high myopia.
And a lot of surgeons are interested in phakic IOLs because there is no capital investment or CMCs. So all they need is just their cataract tools, microscope and other devices. So that's why it's more tempting for the surgeons.
They need to buy your cannula.
Yes, it's not very expensive.
I was very pleased to hear in your lecture, in your presentation, that the results on ICRIO is very similar and very comparable to the ICL, because ICL is something that we are very confident, we are very mature in terms of surgeons and to offer to our patients. And after your results, after this lecture, or after all these discussions, I think Bruno, Renato, Yanda, all the resident doctors that are attending this meeting are much more confident to start with this new technology in Brazil, because we are starting right now with Biotech. Is something that we are going for.
Actually, it's much easier to use. It's easier to load. It's easier to load. It's easier to inject than the ICL. Because the ICL, you have to have a pull-through technique, and you'll have to see that the lens is aligned properly, all the 3 holes. The chances of flipping are more. With this, it's just like an IOL cartridge. So if you're used to loading IOLs, then it's quite easy.
Pleased to hear that.
Also, in the toric versions, they have a customized axis with the ICRIL. So the amount of rotation required is very minimum. The maximum you have to rotate is about 15 degrees with these lenses. Whereas with ICL, it could be as much as 22 degrees. So after implanting the lens, you don't have to manipulate it too much inside the eye.
Yeah. Well,
with myopia will certainly have some amount of astigmatism also. So any astigmatism which is more than 0.75 or 1 diopter certainly should go for a toric.
Yeah. The interesting thing is that you have experience. You're doing thousands of phakic IOLs, and now you're using the ICRIO as your preference. So that's for us very much a great endorsement, and we are, like, I echo what Mayumi just said. We are looking forward to starting. We have been really down on the number of phakic IOLs that we could have done in Brazil because of many reasons, and we hope to come back soon to work to start offering patients, and I have some patients actually waiting for that. So this is a real blast to have the opportunity to listen from you, to learn from you guys that have the real experience. So, and you don't only have experience with because some people, they don't have the excimer laser or the femtosecond laser for the corneal procedure. So they just say, oh, let's do phakic IOL in everybody. Or they have an old excimer laser, but you do the state of the art with everything. So you're a great corneal surgeon. You have the state of the art technology with the Zeiss equipment, and you can offer the patient the best. You're really doing the best for the patient.
We actually market it as comprehensive refractive solutions. So we tell the patient that you want to get rid of your glasses, we'll tell you what is best for you. We have all the technologies, so we'll decide what is best for you and then do it.
Yeah, I agree. I couldn't agree more. Comprehensive refractive solution is really good.
Great approach. Thank you. Thank you for sharing your knowledge.
Thank you.
Thank you.
So we're approaching the end. Do you want to give any final statement, Dr. Mayumi and Dr. Fontes?
As I said before, this is very interesting morning. In Brazil, it's still morning, and evening for you guys there. I think it was the first step that we needed here to start with it. This confidence that we need to be not only in terms of efficacy, but the safety of the method of the technology. I would like to thank you very much for that.
Thank you. Thank you so much. Thank you, Dr. Renato, and Dr. Mayumi, Dr. Bruno. It was a pleasure, and I hope all the delegates benefit from this. And I think Biotech will make it available also for those who have not seen this webinar. They can actually log in and then access it even later.
Maybe we can put it.
Have a nice day.
Yeah, the website. Thank you.
Thank you, everyone.
Keep safe. Keep safe. All the best to you guys.
You too.
Good to see you all.
Yeah.
Take care.